Hello, my name is Dr. David Armstrong. I would like to talk with you about hemorrhoidal ligation using the Cook, SHORTSHOT and TRIVIEW anoscope. First, let's briefly review the involved anatomy and physiology. Internal hemorrhoids are located in constant positions within the anal canal, in the left lateral, right anterior and right posterior locations. Internal hemorrhoids are also located above the dentate line, which is the ring of anal glands marking the boundary between the autonomic sensory innervation above and the somatic sensory innervation below the dentate line. The autonomic innervation above the dentate line is relatively insensitive to painful stimuli, whilst the somatic sensory nerves are extremely sensitive. For this reason, internal hemorrhoids, which occur above the dentate line, can be treated by several non-surgical means, such as rubber band ligation, with very little discomfort, with little or no anesthesia, and in an outpatient setting. External hemorrhoids, by contrast, occur below the dentate line, and any surgical excision in this area requires either local or general anesthetic. Rubber band ligation of internal hemorrhoids has been a mainstay of clinical practice since it was introduced in 1963 by Dr. Barron. Dr. Barron modified an umbilical cord ligator to use as his ligating instrument and cut rubber bands from a length of urinary catheter to use as his original rubber bands. He originally recommended ligation of one internal hemorrhoid at a time, and this was repeated every 3 to 4 weeks until all 3 internal hemorrhoids had been eradicated. Since that time, it has been demonstrated that it is safe and certainly more convenient to ligate all 3 internal hemorrhoids at the same time. This avoids the need for the patient to return on multiple occasions to ligate all 3 hemorrhoids. This was published by Drs. Lau in 1981 and again by Dr. Lee in 1994. These physicians concluded that, quote, multiple banding in a single session is a safe, cost-effective alternative, unquote. Conventional anoscopes are simple, barrel-shaped or single-slot devices which are used to visualize one internal hemorrhoid at a time. Traditionally, these old-fashioned anoscopes are used to ligate one hemorrhoid at a time. The scope was then removed, and if additional hemorrhoids were to be ligated, the anoscope was reinserted a second and then a third time. This was an inconvenience, and multiple insertions of the anoscope after ligation caused increased pain for the patient each time the scope was inserted. The TRIVIEW anoscope has been designed with apertures located in the left lateral, right anterior, and right posterior quadrants, accommodating the normal anatomic location of internal hemorrhoids. This innovative anoscope avoids the need to reinsert the single-slot anoscope on 3 separate occasions and allows all 3 internal hemorrhoids to be easily demonstrated by a single insertion of the scope. In my practice, it has been shown that patients experience less discomfort after a 3-quadrant ligation using the TRIVIEW anoscope compared with 3 separate insertions of a conventional anoscope. This is almost certainly attributable to having to insert the TRIVIEW anoscope only once compared to 3 insertions required with the conventional designs. I also demonstrated that patients have equivalent results after simultaneous 3-quadrant hemorrhoidal ligation using a TRIVIEW anoscope when compared with conventional anoscopes. And these studies were reported in Diseases of Colon and Rectum in 2002. The convenience and ease of use of the TRIVIEW anoscope combines easily with the SHORTSHOT multi-band ligator and its 4 preloaded bands. This offers one-handed deployment of the rubber bands, and the SHORTSHOT is now available together with the TRIVIEW anoscope to enhance procedural efficiency. Complete disposability of the kit eliminates reprocessing time and minimizes cross-contamination concerns. A safe and very convenient time to ligate internal hemorrhoids is immediately following colonoscopy. Any patient who experiences rectal bleeding should ideally undergo colonoscopy to exclude more serious causes. The vast majority of patients with rectal bleeding are due to internal hemorrhoids. So, after performing a colonoscopy and excluding more serious sources, the physician can evaluate and treat the internal hemorrhoids at the same setting. The patient has already undergone a bowel prep, is under moderate sedation after the colonoscopy, and is under constant hemodynamic monitoring. This is therefore an ideal time to perform the three-quadrant ligation. With the patient still in the left lateral position, the TRIVIEW endoscope is inserted into the anal canal. The SHORTSHOT hemorrhoidal ligator is then used to ligate all three internal hemorrhoids. In a recent study we performed in 500 patients who underwent colonoscopy and three-quadrant hemorrhoidal ligation as a combined procedure, reported the following results. 93.1% of patients had complete symptomatic relief within 3 weeks of the procedure and required no additional treatment for the internal hemorrhoids. 6.8% of patients required repeat ligation, usually for persistent bleeding, and 2.5% of patients ultimately required surgical hemorrhoidectomy, mostly for painful external hemorrhoids. No patient required emergency surgery. There were no instances of post-ligation bleeding or of pelvic sepsis. This article and study results are scheduled to be published in the Diseases of Colon and Rectum sometime during 2007. The combination of the TRIVIEW endoscope and the SHORTSHOT ligator is therefore a simple and effective means of treating internal hemorrhoids. It offers a single endoscope insertion option which can minimize related patient discomfort and, in my experience, affords a safe and effective treatment method. Combining colonoscopy and three-quadrant hemorrhoidal ligation is convenient for the patient and the physician alike and is efficient in terms of manpower and resources. It offers time-saving treatment advantages whilst excluding other causes of rectal bleeding.